So here's something annoying. I was just lecturing on this stuff, and the battery on my video camera went off, and I'm not entirely sure where I left off. So last I think I was talking about was ARDS and this thing called whiteout. Um, so ask me in class, and then we can go. I can describe again if I did not make this clear. I lost my thing. What this whiteout thing means, and basically what I was saying is, in a pneumonia, it's usually unilateral. I mean, it can develop into bilateral, but it's still like in, like clumpy spots. In ARDS, it starts. You get this fibrotic laydown tissue bilaterally, and it usually comes up from the bottom up, and that's called a whiteout, and that's usually an ominous sign. So I'll go back and review the tape and find out where it left off, and if I forgot to tell you anything, I'll tell you in class. So that is ARDS. Then the next thing I wanted to talk about that's important is pulmonary hypertension. And we talk about pulmonary hypertension a little bit when we're going to talk about hemodynamics. Pulmonary hypertension is the same thing as hypertension. It's just in the pulmonary system. So you know that here's your heart like this, and the right ventricle pumps blood into here. That's where the perfusion takes place. So the carbon dioxide comes in here, and the oxygen goes out, but all of this in here is really vascular. So you have all of this, these vessels in the pulmonary system, and sometimes that can have too much tension in it, just like your patients who have systemic blood pressure and they have a blood pressure that's higher than 140/90. The same thing can occur in the pulmonary system. So there are a couple things that we can do, similar to what we do for our patients who have systemic hypertension, which is, we just call it hypertension because unless you're saying pulmonary hypertension, you just assume that it's systemic hypertension. And you'll remember that you've got those two systems. You've got the pulmonary system coming off of the right side of the heart, and the systemic system coming off the left side of the heart. And both of them, it's in the arterial system. It's away from the heart. So in pulmonary hypertension, you treat it the same way. There's certain medications you can give. You want to create vasodilation in the pulmonary system. You want to minimize fluids, everything that you can do to reduce the pressure in the pulmonary system. Because if you have too high pressure in the pulmonary system for too long, it can lead to other complications, pulmonary complications. So I do want you to know a little bit about that. There's 5 different categories about pulmonary hypertension, and this is very similar to systemic hypertension. There's several different reasons a person can have it. Sometimes we have no idea why a person has hypertension. We just treat it anyway. So read up on pulmonary hypertension. The next thing I wanted to talk about is PEs, pulmonary embolism. My thing is really a mess. The thing I wanted to, I cannot stress this enough, and I'm going to redraw this so it doesn't turn out to be a hot mess. I cannot stress to you how many times students get this confused about a pulmonary embolism. A pulmonary embolism will always come from the venous side of the vasculature. Okay, now here's your heart, like this, okay? Right atrium, I know we've done this a bunch of times now, right ventricle, left atrium, left ventricle. Okay, the blood is going to leave the left ventricle, it goes up into the aorta, and then through all of the arteries, this is the carotid arteries, and it comes down here, feeds the heart, comes down through your abdominal aorta, blah, 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 goes to every single organ. This is a foot, you know, this is your hand. Everybody, kidneys, everything gets on the arterial side because it's carrying oxygen. That's on the arterial side. And then every single organ and system has little itty bitty capillaries, little tiny capillaries, where the oxygen carbon dioxide exchange happens systemically. We just talked about how it happens in the lungs. Now it happens systemically. So now the oxygen that's in here, it dumps into the tissues, and then it picks back up the carbon dioxide. And you can think of carbon dioxide as like, you think of feces in the GI tract. Carbon dioxide is the byproduct of what your organs don't need. And so it dumps it back into the bloodstream, but at the other end of the capillary, when the carbon dioxide comes in on this end of the capillary, now you're in the venous side. So everything over here is arteries. Every single thing. So if there's anything in this system, anything, if you have a blood clot over here in the left atrium, and it's going to come from the left atrium, and then it'll go into the left ventricle. If you have any little debris or cholesterol or a blood clot or something on the systemic side, it will cause ischemia. It will not cause a PE. It can't get back to the lungs. Problems on this side are going to cause like a stroke. If it goes up to the brain, it'll cause claudication, meaning owiness because of not enough oxygen. Your decreased urinary output. If it goes into the kidneys, it's going to cause a heart attack. If it goes here, that's on the arterial side. Nothing on the arterial side will cause a pulmonary embolism ever, because it can't get back through these little itty bitty like one cell capillaries. It just can't. However, after it gets back into the venous side, so here's my guy's other foot. So now I've got the venous side. It's carrying carbon dioxide. It's trying to get back up to the lungs. So now it's coming back up. This is the venous side over here. Now, if I get something developing in the venous side, and pretty much the only thing that's going to be is a blood clot, then it's going to travel up into my subclavian vein, dumping into the right atrium. And now these are big wide veins. Subclavian vein is big, and remember down here it's tiny. It's like the branches of a tree, like the roots of a tree, real tiny, way out there. And as those roots get closer to the trunk of the tree, those roots get bigger and bigger and bigger. So if you have a little clot that starts down in the lungs or something, because if your patient's been laying in bed too long, if your patient has coagulation problems, they've just had surgery, they're in a cast, there's some reason they're going to have some pooling in that blood, in that leg, they're going to develop a little clot. The clot is going to keep swimming upstream, and it's having a grand time because those things are getting bigger and bigger and bigger. So that clot is just having a grand old time swimming all the way up there. And the patient may or may not know it, depending on how big this clot is, but it gets higher and higher. It gets up in here to the right atrium, right ventricle, still have a nice big open stream, and then it goes into your pulmonary system. Then, I need a better thing. I think I left my black one in the other room. So now, on the venous side, now you're in here, and now it goes into my lungs, like this. And now once it gets into the lungs, now it's like you can think of this as like the trunk of the tree. These are the roots, and up here is like the top of the tree. Well, it's nice and big, but now it's getting smaller and smaller and smaller down near the leaves of the tree. And like in the leaves of a tree, it's starting to get really, really small. So depending on the size of this clot, it's going to get lodged. It's going to get stuck in there. Depending on how big it is, if it's real small, you might just have a small PE, and it's going to infarct down here So you might just have a small area of ischemia, but if it's really big, you could infarct an entire lung. That's called a pulmonary embolism. Make sure you understand the difference between a clot on the left side of the heart, that's in the arteries, and a pulmonary embolism, which is going to be caused by a DVT, a deep vein thrombosis. Okay? Don't get that screwed up. Patients do that all the time, or students do that all the time. And it totally depends on the size of the clot. If you know that your patient has a clot, and we're going to talk about that when we talk about some of the peripheral vascular diseases, they can put what's known as like a filter in. They put like a little umbrella filter, so if you know that your patient has a clot, and if the calf starts getting big, if it gets hot, if it gets swollen, if it's painful, your patient's been laying in bed for a long time, your patient has just gotten off an airplane, they've been traveling for a long distance, they have clotting problems, and they have all those symptoms, you're going to suspect they've got a clot. You can do Doppler studies to find out if there's actually a clot there, and they can insert a filter so that when this clot gets up higher, it'll stop right here and it won't get up into the lungs and cause a PE. The other thing they do is put patients on heparin and Coumadin and anticoagulation therapy to reduce the clot, and the clot will eventually dissolve, hopefully on its own, before it ends up causing a PE. So I want you to read up on PEs. Sarcoidosis, it's rare. It's just another lung disease usually people get from traveling. Can cause some lung problems. Not real common. Chest tumors. The thing I do want you to know a little bit about, they call it chest tumors. Basically, it's lung cancer. Lung cancer is the leading cause of cancer deaths. It's not the leading cause of cancer because we have other cancers that occur more often, breast cancers, colon cancers, things like that. But lung cancer is more deadly than either one of those. And the leading cause of that is carcinogens, i.e. smoking. So it is essential that you prevent or teach your patients, especially if you're working in the community or with groups of adolescents, people that are around, smoking a lot. It is essential that we teach our patients to not smoke. And I am a huge advocate that I do not believe nurses should smoke. You know you know what it causes. It's ingesting carcinogens. You smell like smoke around your patients who may be trying to quit smoking. It's just a really awful, deadly habit. So once a patient does develop a lung cancer, oftentimes by the time they identify it, it has already metastasized somewhere else. But the treatment of choice is usually surgery. So usually if they find out that there is a malignancy in the lung, they will go in and remove it surgically. And they'll either take out just the tumor itself, or they may have to take out an entire lobe, and sometimes they have to take out an entire lung. So obviously, once again, prevention is the treatment of choice. But I do want you to know about the different kinds of surgical treatment for lung cancer. If the cancer has spread beyond the lungs, then the patient can either get chemotherapy or radiation. If it has gotten into the lymph nodes, that's when we do chemotherapy, because chemotherapy goes in through the IV and it will touch everything. And I think I've told you guys this before. It affects fast-growing cells, which is why somebody on chemotherapy is nauseated, because your GI tract is very fast-growing. Your hair, your nails, they get mouth sores because mouth to anus is all very fast-growing. The cells in there replace themselves about every 3 to 4 days. That's chemotherapy. Radiation therapy is if they get some of the tumor, but not all the tumor. They might want to radiate the area to try to kill any other cancer cells that may have been left behind. Sometimes they will do what's called debulking a tumor, meaning they know they're not going to get the whole thing out, but they reduce the size of it just to improve quality of life for a little while. That's called debulking a tumor, and they do that for brain tumors, all kinds of different tumors where they're just trying to buy a little bit of time. Okay, then the last thing I wanted to talk about in this chapter, I can't remember if I talked about cor pulmonale in this chapter or not. Cor pulmonale is right-sided, basically it's like right-sided heart failure. If I didn't talk about this, remind me, and we'll talk about that in class, because it can cause back up and cause some additional lung problems, and you'll see that every now and then. You see right-sided heart failure. So the last thing I wanted to talk about is trauma to the chest. Blunt force trauma to the chest is not super uncommon, because when you're driving like this, if you're in a car accident and hit head on, you can get smashed in the chest with a steering wheel and cause blunt force trauma. The thing that we worry about in our patients who have had accidents and been in traumas is if the ribs break, and I think I showed you this picture before, if you've got your ribs like this, if they break and become jagged, they can break through the lining of the lungs, and they can, the layman's term for it is called puncture lung. We call it a pneumothorax or a hemothorax, and it depends. If you have blunt force trauma, or penetrating trauma is another one, like if you have a knife injury or something that cuts in, what happens is you get rushing of air in here, and this lung now, because remember it's on a negative pressure, if you get air into that negative pressure space, it'll collapse it very quickly. It's like popping a balloon. And this will, let me erase some of this stuff. We'll give our guy a pneumothorax on this side. So let's say he has a gunshot wound. So he has this will be my gun. I guess I'm not very good at that. So he gets a gunshot wound, and it breaks open the lining of the lungs. This lung now then will collapse down like that. This in here is called a pneumothorax. There's air in here, and it's pushing the lung this way, because this is all under negative pressure. This is going to come in under positive pressure. It's going to push the lung that way. A hemothorax is the same thing. If this fills up with blood in here, it can also shove the lungs over. There's another thing called flail chest. Flail chest is always a medical emergency. That's usually where 2 or 3 ribs have gotten broken, and the whole section, so instead of the ribs going in and out with respirations, a whole section is broken, so they kind of suck in. I'll show you a picture of it. The problem with these situations here, you can treat them. You would put a chest tube in, and you'd start to, like, if it's in a situation like this, you would put a chest tube in very quickly. You'd probably put it to suction, because you want to reinflate that lung. You want to, if it's an open wound, you want to seal that wound very quickly, like put a Vaseline gauze on it or something, because you want to prevent more air from getting in there. The problem, the biggest thing that we worry about, is compression of the thoracic organs. So if this lung starts collapsing and moves the heart and the trachea over, that can be a medical emergency, because it's putting tremendous pressure on the heart and trachea, and it can cause death if you don't intervene very quickly. So when you get a wound, a penetrating wound, an open wound, a wound that causes hemothorax, even if it's closed but there's bleeding in there and shoving that lung over, you have got to get a chest tube in there and start pulling some of that stuff out. And probably they'll be on a ventilator and oxygen and things like that. So read up about flail chest, blunt force trauma, penetrating traumas. I think there's some good pictures. Yeah. Some of the pneumothoraxes are over on page 615. Sometimes your patient can have a tension pneumothorax. I think I talked about that in one of the other lectures. Sometimes these blebs in here, or the alveoli, will just blow for a variety of different reasons. Sometimes drug abusers have this, patients who are malnourished, dehydrated. They can have a spontaneous tension pneumothorax. And so depending on the severity and the size of it would be depending on how you treat it. Some of them will resolve on their own. Other ones need chest tubes and oxygen therapy. So those are the things I wanted you to know about. There, the last little blurb in there is in subacute emphysema. I think we also talked about that, where some of the oxygen can get up under the chest and you can feel it kind of like bubble wrap. So that's what I wanted you to know about chapter 23. Okay, see you next week.